Nampak slide ke ni Google lain?
Nampak.
Nampak Okay. Okay, Assalamualaikum and good afternoon to everyone. So our group will present the topic edema first. So for the case history, a 65 years old man attend the medical outpatient department for routine follow-up and renewal of his prescription of his regular medication. The chief complaint is he have a swollen leg and difficulty walking. For the history of presenting illness, his ankle first started swelling about 4 weeks ago. He is unable to wear his shoes on account of the swelling and can only wear slippers. He also complained that his abdomen feels distended. He finds it hard to walk any significant distance due to his leg swelling and also due to the increasing of shortness of breath. He said he had a difficulty sleeping over the past 4 weeks, often waking up due to the shortness of breath. The past medical history he had a myocardial infarction 10 years ago. He has a hypertension which was diagnosed 2 years ago and also have a type 2 diabetes mellitus for the past 20 years. For the drug history, he is on the following medication. He's on aspirin, glyceryl nitrate sublingual spray, amlodipine, atenolol, metformin and also glibenclamide. His family history is not significant and the social history, he is a retired clerk and lives with his wife with an adult son. He is a lifelong non-smoker and doesn't consume any alcohol. So for the first question, what is your main differential diagnosis based on the history given and state the reason? So we decided the main differential diagnosis is the pulmonary edema secondary to congestive heart failure. So the reason from the history is that he had a paroxysmal nocturnal dyspnea. So this is because when the patient is sleeping, there will be a redistribution of the blood. So in heart failure patient, the heart couldn't handle the increase of the volume, hence cause the pulmonary congestion and leading to the shortness of breath. But there are also other theories that say the waking up is due to the reduced responsive of the respiratory center during sleeping, and also because of the reduce of the adrenergic activity in the myocardium during sleeping. And then from the history, the patient also have pulmonary and the peripheral edema. So in heart failure patient, because there will be increase in the left atrial and ventricle pressure, so it will cause the increase in the pulmonary capillary pressure as well. So when this pressure is higher than the oncotic pressure, it will cause the fluid to move into the interstitial space and causing the pulmonary edema in heart failure patient. And he also had a peripheral edema, which is due to the reduce in the perfusion to the renal and also because of the activation of the RAAS system causing the edema, salt and water retention. And the patient on the history also have a dyspnea on exertion. So this is because of the reduce of the tissue perfusion, and because like in he also have a pulmonary edema, so this cause difficulty in the gases exchange and also the heart failure causing the reduce of the tissue perfusion to the peripheral tissues, causing the breathlessness during exertion. And then for the second question, what are the possible underlying causes for this diagnosis? So in the history, he had a myocardial infarction 10 years ago. So this infarction will cause the injury damage to the myocardium and also scars tissues, which reduce the contractility and as a risk factor to the heart failure. And then he also has take few drugs that can he also can have a drug-induced peripheral edema, which is he take the amlodipine, which is the calcium channel blocker. So it can cause the induced peripheral edema. And then he also had a diabetes mellitus and hypertension, which both serve as a risk factor to develop coronary artery disease, which later as a risk to the heart failure as well. And then for the third question, what other question would you like to ask for further clarify the suspected diagnosis? So firstly, I would like to ask for the patient if he had any orthopnea, whether he need to add more pillows to alleviate his body before sleeping. And then whether the patient have experienced any chest pain, it may be secondary due to the ischemia or because of the heart failure. And then whether patient experience palpitation with or without lightheadedness, because of the tachycardia to decompensate the heart failure. And then whether patient have any cough, which shows the pulmonary edema may become worsened, and also whether there are any presence of pink frothy sputum, and whether patient experience nocturia, because during the day the renal perfusion will be low, and then during the night it will be normalized again, so the patient may have the urge to urinate during the night. And then also whether patient experience dizziness, confusion, difficulty of concentrating, and also fainting because of the reduced perfusion to the cerebral. Okay, next.
Okay, so for the next, okay, for the next question, question number 4, what other differential diagnoses are there for peripheral edema in this patient? So the first one is congestive heart failure, because in this case, there will be decreased cardiac output or ejection fraction lead to pulmonary and peripheral venous congestion, resulting in pulmonary edema and peripheral edema respectively. So in this case, edema is bilateral and symmetric. Second one is hepatic disease. In this case also, there will be a bilateral edema caused by portal vein congestion, leading to an increase in capillary permeability and a decrease in plasma oncotic pressure, all due to a decrease in synthesis of albumin by the diseased liver. Third one is renal disease, which is there will be also bilateral edema caused by protein loss, especially albumin, such as in the case of nephrotic syndrome, and an increase in plasma volume due to renal retention and activation of neurohormonal factor. Number 4 is venous insufficiency, usually bilateral edema caused by the failure of venous return secondary to chronic deep venous system damage or incompetence. And the last one is cellulitis, where there will be edema with signs of infection like fever, elevated white blood cell count, and most common in patients who are obese and chronic medical condition like DM. Next slide. Okay, for the next question. Question number 5, what specific question would you need to ask to rule out this other condition? The first one is hepatic disease. Okay, in order to rule out this one, we need to ask whether this patient is experiencing or have any history of easily bleeding or bruising, because we know the liver plays a central role in clotting process. So if the patient have acute or chronic liver disease, so they are very much associated with coagulation disorder due to multiple causes, for example, decreased synthesis of clotting or inhibitor factor. And also as for in terms of weight, if the patient experiencing weight loss due to loss of appetite, symptom of nausea or clinical sign of jaundice. For renal disease, as for history of foamy urine, hematuria, itchy skin or altered mental status, this is a common symptom of kidney failure, or we can call it for the medical term is delirium. So it is all due to a combination of toxin that is affecting the brain. For venous insufficiency, we can ask for history of pain, cramps, or the clinical sign of varicose veins. And for cellulitis, ask for fever, skin redness, swelling and pain, or skin disease, for example, eczema. That's all. Thank you. Next.
Good afternoon, everyone. So from the system review, he has a poor urinary stream associated with hesitancy and post-void dribbling. These symptoms have been present for about 3 years. So on examination, the pulse rate is 54 over minute regular, respiratory rate 20 over minute, blood pressure is 140 over 90, and temperature is 37 degrees Celsius. So from the head and neck examination, it shows JVP visible 2 centimeter above the clavicle. And then from the CVS examination, the apex beak localized in the 6th intercostal space, anterior axillary line, and heart sound 1 and 2 present, S3 audible, grade 3 over 6 pansystolic murmur was present, heard loudest in the mitral area radiating to the axilla. For the respiratory examination, shows moderate intensity, vesicular breath, sounds with fine inspiratory crepitations in both lung bases. And for the abdomen examination, it has mild distension, soft non-tender non-palpable masses, smooth liver edge felt 2 centimeter below the right costal margin. The lower limbs shows pitting edema up to the knees bilaterally, and the CNS PNS examination no focal deficits. Next. So for the questions is what is your main diagnosis based on the examination finding, and explain your reasoning. So we came up with a diagnosis of heart failure. So why? Because from the vital signs, the pulse rate shows he has bradycardia. It may due to drugs, because from the drug history, we know that he takes beta blocker, which is atenolol. So beta blocker, also called beta adrenergic blocking agents, is the actions of beta blocker by the blocking the release of stress hormone, which is adrenaline and noradrenaline, will give the result of slowing heart rate and reduce the force of pumping the blood throughout the body. Next, from the BP, it shows he has mild hypertension, so heart failure will cause low cardiac output, which lead to the neurohumoral activation, causes vasoconstriction of blood vessels, then increase the afterload, and finally increase the BP and cardiac work. Next is apex beats in the sixth intercostal space, anterior axillary line. It is indicative of the left ventricle enlargement. S3 audible, which is due to left ventricular function. Due to poor left ventricular function and usually associated with elevation of left atrium pressures and left ventricle and diastolic pressure. Next is grade 3/6 pan-systolic murmur, heard loudest at mitral area and radiate to axilla, is due to mitral regurgitation in the heart failure patient. Next. Patient also has a fine respiratory crepitation in both lung bases. It is sign of pulmonary congestion, which can lead to the pulmonary edema and obstruct the small airway and alveoli. Next is mild abdominal distension or ascites. It occurs usually because of combination of hepatic congestion and portal hypertension that can lead to the peritoneal transsudates. Next is pitting edema up to the knees bilaterally. It is due to pulmonary congestion, which can cause increase in systemic venous pressure, increase the hydrostatic pressure in gravity-dependent areas such as legs. Next question is briefly explain pathophysiology of abdominal finding. Next. So the first one is the ankle edema and ascites. So heart failure can cause blood backs up from the heart and accumulate in the pulmonary vasculature due to pulmonary congestions. So backs of the blood into the systemic venous circulation will cause increase in hydrostatic pressure in the veins, forces fluid out into the interstitial tissue to the gravity dependent area and lead to the ankle edema. At the same time, right high venous pressure are transmitted to the liver and cause hepatic congestion. This will lead to the increasing of hepatic venous pressure, increased hydrostatic pressure in the veins, forces fluid out into the interstitial tissue, then build up the peritoneal transsudates, finally lead to the ascites. Next is dyspnea. Dyspnea, so heart failure can reduce the cardiac output. So it will impact the lung and systemic organ perfusion, especially muscle, cause tissue hypoxia, and then increase the anaerobic respiration and lactic acid production, and cause respiratory centers try to compensate by increase in the respiratory rates and finally lead to the dyspnea. And other than that, heart failure also can cause pulmonary congestions and increase the pulmonary venous blood pressure, which forces fluid out of the capillaries into the pulmonary interstitium and alveoli, causes pulmonary edema, reduce the lung compliance, so that the respiratory muscle need to work harder to ventilate the lungs and finally lead to the dyspnea. Next. Next is a paroxysmal nocturnal dyspnea or PND. So heart failure can cause pulmonary congestions and increase in the pulmonary venous blood pressure and lead to the pulmonary edema. However, in the supine positions, so blood and alveolar fluid both will accumulate along the posterior wall of the lung. Then after 2 or 3 hours lying supine, edema in lower limbs is reabsorbed into the circulation, then increase the blood volume and blood pressure. So more blood backs up to the lung and increase the pulmonary congestion, cause pulmonary hypertension and lead to the pulmonary edema. This will reduce the vital capacity and pulmonary compliance and cause PND or breathlessness after 2 or 3 hours of sleep, wakes up patient at night. Next is the inspiratory crepitation. So heart failure will cause more blood remains in the left ventricle after systole. So it will increase the left ventricle and diastolic pressure and cause blood backs up to the lung, increase the pulmonary vascular pressure and forces fluid out of capillaries into the alveoli, lead to the transudative pulmonary edema. The transudate will obstruct the small airways or alveoli. So during the inspiration, the small air chambers pop open and lead to the pulmonary crackles during auscultation. Next. Thank you. That's for me.
Okay, next for the hepatomegaly. Hepatomegaly start with the heart failure, especially at the right side. Then this will lead to the blood backup into the systemic venous vasculature, and then this will lead to the liver congested, and this finally will cause hepatomegaly. And then next for the abnormal finding is pansystolic murmur. As we know that this patient had a myocardial infarction for 10 years. So this MI will lead to the necrosis of the papillary muscle. So papillary muscle will rupture or dysfunction, and this will cause valve leaflet not properly supported, and then will cause mitral valve regurgitation. And this mitral regurgitation will produce pansystolic murmur. And then the last one is S3 heart sound. For this abnormal finding also caused by the myocardial infarction, MI will lead to the reduced systolic function, and then will lead to reduced stroke volume and also cardiac output. So that left ventricle will be overfilled with the residual blood. This causes turbulent flow from left atrium to the full left ventricle in early diastole, and this will produce S3 heart sound. Okay, next. Okay, for the next question, which is what other physical finding would you look for in this patient to elucidate the underlying causes of the diagnosis? So I divided into two, which is the first one is the general signs and the second one is the arterial pulse. Under the general signs, we need to look for the first one is tachypnea, which is due to the raised pulmonary pressure and respiratory compensation. And the second one is the central cyanosis, which is due to the pulmonary edema. And then the third one is the peripheral cyanosis, which is due to low cardiac output. And the last one is the diaphoresis, which is due to the sympathetic activation to increase cardiac output. And the second one is the arterial pulse. The first one is we need to look for the sinus tachycardia, which is due to the increased sympathetic tone. And the last one, we need to look for the low pulse pressure, which is due to the low cardiac output. So these are the other signs for the heart failure. Okay, next.
All right, for next question, the first one will be the basic investigation in emergency department in order to confirm your diagnosis and the reason why you request that particular test. So the first will be ECG, electrocardiograms. So according to the clinical practice guideline 2019, basically when we want to clinically diagnose the heart failure, we need a very detailed history taking and physical examination. But somehow in an emergency setting, it's highly impossible for us to have that particular time to ask so many questions, and especially in older patients and also severe respiratory distress. So what we have to do is whenever patient come with a complaint of SOB, shortness of breath, or also known as dyspnea. So it's basically already give you a strong indication to request an ECG. Bear in mind, the SOB alone is basically has a poor sensitivity and specificity towards the diagnosis of heart failure, because these conditions also can present in another pathological occasions such asthma, bronchitis, and pneumonia. But somehow, the result of the ECG, if there's any what we call suspicious finding or abnormal reading, it somehow will help us to find out the reason behind the presented dyspnea, and also we can find out the etiologies that these etiologies could be the underlying causes to the development of heart failure. All right. Bear in mind that heart failure is defined as, in the simple word, it is a clinical syndromes. Basically, it can be caused by many etiologies, but the most common etiologies will be coronary artery disease, hypertension, and dilated cardiomyopathy. Next. So this is just an example, the ECG result to show when patients are having anterolateral ST elevation myocardial infarctions. You can see there's a suspicious finding in the V2 and V3, the presence of Q wave, and also small Q wave in the VL and V4. And also there is ST elevations in the lead 1, V1, V3 to V6. So this coronary artery disease basically could be the biggest underlying issue or contributor to the development of heart failure. So the benefit, we request the ECG first. We can find out the underlying causes of the presented SOB, and the second one, by finding out this problem, for an example is coronary artery disease, we can start immediately the disease specific treatment, that because that's what we do in the emergency department. We want to give a proper treatment as soon as possible. And there are also another simple test that we can request in emergency cases, which is a natriuretic peptide test. Next slide, please. So basically, the mediators, basically this test is one of the blood tests also. So what happened is BNP and also NT-proBNP will be secreted by the ventricle in response to volume and pressure overload, which also present in the congestive heart failure. So physiologically, whenever our ventricle release this BNP, the BNP will relax the vascular smooth muscle to reduce ventricular preload, and also it will act on the kidney to increase sodium excretion and induce a diuresis. So so the concept of this rule out this test will be a rule out concept, which is it depends on the number of BNP in our blood serum. So just focus on the table below. We can if the test come out to be below than 100, then we can rule out heart failure as the causes of acute dyspnea. But somehow, if the BNP number more than 400, then it's more or less likely the acute dyspnea is due to the heart failure. Beside the BNP, we also can monitor the value of NT-proBNP, which is, if you can appreciate the value to diagnose the heart failure. It's been divided according to age, because this is the limitations of using this parameter. As we're getting older, the numbers of NT-proBNP will be increased as well. So that the main reasons why, in order to diagnose the heart failure, as you're getting older, the number of diagnosing will be increased as well. And also, for both BNP and NT-proBNP, they are specific limitations, is especially in the obese people, because in obese people, the result will be show a lowering of expected compared to the measured value. So it is highly recommended that patients with the body mass index melebihi or excess the 35, which is obese, the severe obese, the finding, we have to double the finding. So for an example, in obese patients, you run this test and you find out the number of BNP will be 150. But due to the limitations of obesity, we have to times the result by itself. Basically, 150 you times 2, so the actual number will be 300. And another limitations will be someone who suffer from a renal failure, because in renal failure, the numbers of the BNP and also anti-pro BNP will be slightly increased. So whenever the result shows 700, then you have to divide by 2. So the actual number will be 350. And this is ECG and the natriuretic peptide test is basically the most common requested test in the emergency department in order to diagnose heart failure. But somehow there are many another lab investigation that we can carry out, which is will be presented by the next presenter. So I think that's all from me. Thank you.
Okay, Assalamualaikum and good evening. So today I present about any other investigation that you will request subsequently and its relevance. So firstly, the chest X-ray. It is to detect the pulmonary congestion, cardiomegaly and any underlying lung pathology. The picture on the left side is the lung with normal, while on the left side it is the lung with cardiomegaly, the chest X-ray with cardiomegaly and pulmonary congestion. Next slide. There are 5 things to look out in chest X-ray in patient with heart failure, and we can remember it as A, B, C, D, E. A is alveolar edema or Bedring opacities. It is the pattern of bilateral perihilar consolidation in the lung, as you can see from the picture beside it. And next B is curly B lines. It is the horizontal lines in the periphery of the lower posterior lung fields. Next is C, cardiomegaly. You can see from the increased silhouette of the heart and also from the increased cardiothoracic ratio, more than 0.5. And for D, it is dilated upper loop vessels and also E, pleural effusion. Next slide. Next test is echocardiography. It is for assessment of left ventricle chamber size, volume and systolic function, its wall thickness, evidence of scarring and also wall motion abnormalities. It can also assess the diastolic function of the heart, the valvular structure and function and also congenital cardiac abnormalities. And echocardiography is the most useful and widely available test to establish the diagnosis in patients suspected of heart failure. Next slide. So one of the things that we can assess from echocardiography is left ventricular ejection fraction. It is a measure of left ventricle systolic function, and the formula is stroke volume, the volume of blood ejected during systole, over divided by end diastolic volume, the volume of blood in ventricle at the end of diastole, times by 100. And left ventricular ejection fraction can be used to classify the types of heart failure. If the LVEF is lesser than 40%, we can conclude it as heart failure with reduced ejection fraction. This is usually heart failure with systolic dysfunction, which means that heart cannot pump out the blood efficiently, causing less volume of blood is distributed to the body, so the fraction is reduced. For LVEF more than 50%, it is called heart failure with preserved ejection fraction. In this patient, the ejection fraction is normal. However, it is normal because the end diastolic volume is lesser. So that's why the fraction is still normal. But still the volume of blood pumped out to the body is not adequate. And for LVF, 41% to 49% is called heart failure with mid-range ejection fraction. Next slide. This is the example of echocardiograph of patient with systolic dysfunction. Note that there is dilated left ventricle. And also for the picture on the right side, it is for patient with heart failure with this diastolic dysfunction, which is we can see that there is normal left ventricle with hypertrophy. Next slide. Other investigations that can be done is full blood count. It is to check for any infections or anemia that can worsen the heart failure. Renal function test and liver function test. For renal function test, we might have raised creatinine level, which is signs for impairment of kidney. For liver function test, we might have abnormal levels of ALT, AST, and other liver enzymes, also the signs of impaired hepatic function. Because this test can be done because one of the differential diagnosis is renal disease or liver disease. Next is serum glucose. It is for assessment for diabetes mellitus, and lipid profile, the assessment for hyperlipidemia, and lastly urinalysis to look for proteinuria and glycosuria. I think that's all from me. Thank you.
Okay, quite a simple, straightforward case. Patient who presented with heart failure, presented with edema. So when you have patient with edema, okay, you need to have a list of differential diagnosis for it. Okay, it could be cardiac related, it could be kidney related, it could be liver related. All the failure, heart failure, liver failure, kidney failure, or it may be due to other causes, such as medication induced, such as the one that we use in hypertension, namely calcium channel blocker, or it could be due to certain local causes, such as cellulitis or venous insufficiency. Okay, so it is a basic, a straightforward case whereby when we have a patient who has an ischemic heart disease, later on the heart function is not that good, compromise the heart function, leading to heart failure. Okay, so this is an example of a patient who presented with congestive heart failure. Okay, so I think your friend has presented quite thorough in terms of how to investigate, okay, and also has earlier discussed regarding the possibility of various forms of differential diagnosis, and also in terms of what relevant point that we need to gather during history taking, and also elicit how to elicit the relevant physical finding in patient who presented with congestive heart failure. Okay, any question to the presenter regarding the first case? Okay, S2 audible, or we call it as presence of S2 gallop. Okay, remember, this is a classical finding of patient. Whenever you have a patient who presented with fluid overload, try to auscultate this kind of patient and appreciate what is the S3 heart sound appear to be.
In house pain 2 years ago, and he is on no medication and also has no known allergies. His father died of a heart disease at the age of 45, unspecified heart disease over here. And his mother, who is still alive, suffers from type 2 diabetes mellitus. He smokes 20 cigarettes a day and has been smoking since early 20s. He does not consume any alcohol. On examination, his vital signs are as follows, with a pulse rate of 100 per minute, with a regular pulse, respiratory rate of 20 per minute. His BP is 154/90. His temperature is 37 degrees Celsius. He is sitting up and appears sweaty and also anxious. The hands are unremarkable, and the examination of the head and neck reveals antelasma and also corneal arcus, and the JVP is not raised. The apex beat is in the fifth intercostal space, mid-clavicular line, and normal in character. Heart sounds 1 and 2 unheard, and there are no added sounds or murmurs. The lungs are clear to auscultation. The abdomen is also soft and non-tender. So this is the case that is given to us. So moving on for part A, first question is the differential diagnosis based on the history given and state the reasons. So the main differential diagnosis, acute coronary syndrome, more specifically, this should point towards MI or some form of that. So the reason is a 1 hour history of severe chest pain, which is the one that the patient has been presented to the emergency department is, and it is described as also a crushing type of pain. And also for the past week, which is a week prior, he has been he told the doctor that he had mild central chest pain with a duration of 10 minutes each following mild exertion, which points toward the stable angina. So possibly the stable angina had progressed. And next is a history of being a little too high on cholesterol might point towards arteriosclerosis, which is also another form that may produce acute ACS. And lastly, a family history of heart disease and type 2 diabetes mellitus in the family increases the risk of having heart problems, and also a history of smoking, which is also a risk factor for the ACS. So we might actually want to calculate the exact packages for this smoking. Next slide. Okay. So other questions would you like to ask regarding this? So what was the man doing before the attack happened? Because sometimes the patient might say it's actually stable angina, and we forgot to mention that he was exerting himself beforehand. And ask him to describe the pain even more. What is severe? So, for example, in the trigger it says that it is severe chest pain. So we need to ask him what is the meaning of severe. So give him a scale from 1 to 10, and then tell him that 1 is no pain and 10 is the most severe pain, and then just tell him to point out which how much is the pain is. The site, the onset, the characters, all of this has been mentioned. The radiation, however, is not mentioned in the trigger, so you need to ask about that. Associated with is already told as well. So time is also told as well. So medication, the patient already said that he is on no medication. However, he did not mention any usage of supplements or herbs. In short, just ask for any traditional medicine. And next, did he do any lifestyle changes following the little high cholesterol levels? So maybe after the meeting with the doctor and then knowing that he has a bit high of cholesterol level, maybe he changed his lifestyle and start eating less food high in cholesterol. So maybe his lifestyle is no longer a risk factor to development ACS, so we might want to exclude other reasons for his chest pain. And as usual, since currently there's a COVID pandemic, so we ask for COVID status and history of exposure, and also if there is any past infections. I think that's all from me. Next presenter.
Okay, hello everyone. Now I'm going to proceed with other differential diagnosis. So you know that chest pain doesn't necessarily means that the patient have heart problems. There are lots of differential diagnoses that of chest pain that could involve other systems beside cardiovascular system. Like for example, GERD, the gastroesophageal reflux disease, which involve the GIT system. So the GERD is have a characteristic of retrosternal burning pain, or it is most commonly known as heartburn. So smoking is a risk factor because it can weaken the lower esophageal sphincter of the esophagus, so it can cause the reflux. Okay, next is the pericarditis. So it is characterized by the sharp stabbing chest pain, and it can also radiate to one or both of the patient's shoulder. And sitting up and leaning forward could ease the pain, could relieve the pain, and while lying supine could exacerbate the pain. So, and it's also usually associated with elevated temperature. And then there's also musculoskeletal problems, like for example, muscle spasm or muscle tear, or for example, the pectoralis muscle tear, and also history of trauma, and it can cause an aching pain. Okay, and then next is the specific questions to ask to rule out these other conditions. So we can ask about the pain sensation, whether it is maybe burning, dull, or sharp. Like for example, if the patient has GERD, then it is burning pain. And if patient have musculoskeletal problems, then it's an aching pain, and pericarditis, maybe sharp pain. And then you can also ask the patient whether they have pain during swallowing or after meal, and also maybe ask whether the patient have acrid taste. If the patient have GERD, then the regurgitation can leave an acrid taste in the patient's mouth. And then you can also ask the patient if the patient went to dentist before, because the dental procedure is also a risk factor for an infective endocarditis. So infective endocarditis can also cause chest pain. We can ask for history of infection and also prosthetic heart valve, which is also the risk factor of infective endocarditis. And then, okay, next is we can ask for the history of exercise. Particularly, he tried to lift heavyweight objects or exercise. So this can cause like the muscle tear, and yeah, we can rule out other musculoskeletal problems. Okay, next. All right, that's all from me.
Okay, for question B, number 1, what is your main differential diagnosis based on the history and the examination? So, in my opinion, it's acute coronary syndrome and its reasons are because from the history itself, we have elicited several risk factors that could possibly cause acute coronary syndrome, like high cholesterol levels, family history of heart disease, and type 2 diabetes mellitus. The patient is a smoker and he has high blood pressure. So these are all the signs and symptoms that could be indicative of acute coronary syndrome. Also, on examination, the patient has then thalassemia and corneal ulcers that indicates hypercholesterolemia, which is also a risk factor to cause acute coronary syndrome. And in my opinion, I agree with what Amirul said just now, because he said it's highly indicative of angina, because I feel from two important points from the history and examination, which says that the patient has a mild central chest pain for 10 minutes on exertion and is relieved by rest. Where this usually happens in angina, whereas for myocardial infarction, chest pain occurs at any time. So it doesn't necessarily has to be on exertion. The patient can be at rest and they can still have chest pain. And also on examination, it says that the patient has no murmurs. Myocardial infarctions usually have heart sound 3, and which are murmurs, whereas angina, I'm not really sure whether they have murmurs or not, but from the overall history and examination, I think the diagnosis, the main differential diagnosis for the case should be angina. Next slide. What physical findings might be present in a patient with the main differential diagnosis? So the major physical findings are xanthelasma, which indicates hypercholesterolemia, obesity, pallor, diaphoresis or excessive sweating, tachypneic, tachycardic, and cool claiming skin, which means cyanosis. Next slide. What other differential diagnoses are there based on the history alone, and what physical findings would you expect for each of these differential diagnoses? So from the history alone, the first differential diagnosis that could be elicited is pericarditis, which also causes chest pain, sharp and stabbing chest pain. But the other physical findings that we need to expect if the patient has pericarditis is pericardial friction rub, low-grade fever, and palpitation. Next is aortic rupture. In a patient with aortic rupture, they also show similar chest pain as in the case, but besides that, they also have presence of systolic ejection murmur and neurological signs like leg pain, loss of consciousness, and they can even have paralysis. 30 is pulmonary embolism. In pulmonary embolism, patients have chest pain and also excessive sweating, as shown in the patient in the case. So besides that, what we can expect from a patient with pulmonary embolism is leg swelling, sinuses, and tachycardia. Next slide. Okay, thank you.
Okay, Assalamualaikum and good evening. Today I will explain about question C. Actually, I have two questions. Explain basic investigation can be done in the first question. And the second question is reason with relevance of such doing the investigations. So the first one is electrocardiograph with ECG. Reason is patient presented with symptom and signs of acute coronary syndrome. So ECG is a reliable investigation to detect is it any ACS or not. And then relevance. Any abnormality of ECG indicate damage or abnormality of the cardiac tissue. Due to tissue ischemia, cardiac tissue are damaged, hence the pathway of electric conduction of the heart also affected. So this affected conduction can be shown by alteration recorded in the ECG strips. Next. So what information that can be gained from ECG? So the first information is ST elevation. So it indicate there is STEMI, ST elevation myocardial infarction. So STEMI means it is severe, the whole thickness of the myocardial tissue is affected. So the next one is differential diagnosis, which is non-STEMI. Non-STEMI means there is not a transmural. There's endocardium layers is affected, but not the whole layers. So it's important to differentiate between STEMI and non-STEMI because the management is different. And then from ECG also, we can gain information about the location of the heart tissue that is affected, whether it's lateral, inferior, anterior, or posterior, or inferior, based on the location which ECG is affected. And then we also can gain information about there is a past history of the ACS. For example, we can gain information from the Q wave. The presence of Q wave means there is a past history of the myocardial infarction and the T wave elevation. And then we from ECG also we can get information about is it the MI has progressed into the complication. As you can see here, like arrhythmia, heart failure, valve disease, this kind of the complication we can gain from the ECG. So there is a lot of information that we can gain from ECG. That's why ECG is a prime investigation for acute coronary syndrome or any heart disease. Next. So this is this slide I just put here in order for you to see what progress can be from the ECG. Next. Next is cardiac biomarker. Its reason is to classify the acute coronary syndrome. So in acute coronary syndrome, cardiac biomarkers such as troponin, which is the gold standard, troponin I and T, CKMB, which stand for creatine kinase, myoglobin and brain, CK, creatine kinase and myoglobin is used, and any rise of this cardiac biomarker indicate myocyte injury. As you know, during injury, myocytes, the cells, release enzymes into the bloodstream and rise of this enzyme. So this enzyme refer to cardiac biomarkers. So it is very useful in non-STEMI to differentiate non-STEMI and unstable angina. So the difference is non-STEMI have rise cardiac biomarker, whereby unstable angina will have also will not have rise in biomarkers. Next. So here, the relevance of each cardiac biomarkers. Some hospital facilities doesn't have troponin. Even troponin is very useful. So we can use another cardiac biomarkers. So the first is troponin. Troponin I is the best, specific for cardiac myocyte, and lasts longer. It is still rise even though the other cardiac biomarkers back to normal value. CKMB is specific also for the cardiac myocyte, but it is not last longer in the blood circulation compared to troponin. And it cannot confirm that recent chest pain is a myocardial infarction. And then creatine kinase. Creatine kinase is not specific because it also refers to other organ failure also, not only refer to myocyte. And then myoglobin is not specific and not last longer. Next. So from the basic two basic investigation, this is the algorithm of the investigation. So patients who are suspected with ACS from the history and physical examination, we do the ECG first. As you can see, there will be two possibilities, either ST elevation C on ECG or non-ST elevation C on ECG. So there is a ST elevation, there is STEMI. So the management primarily is PCI, percutaneous, and I'm not sure what is PC, but it's actually it quite invasive. Is what call that, and just to make the blood vessel become dilated, PCI, and then when it is delayed, I think more as 12 hours, we use fibrinolysis medication. And then if it's not STEMI, positive indicate non-STEMI, we use medical management. In unstable angina, it also medical management, and we can discharge earlier and arrange a follow-up investigation. Other investigation that we can do is a blood test for cholesterol, for blood count to see is it any associated chest pain due to anemia. And I think that's all. Thank you.
Okay, is it that's all? That's all the presentation?
Yes, Doctor.
Any, that's all? Okay, all right. ACS patient who present chest pain with chest pain, acute coronary syndrome and also heart failure is a common case in medical, in internal medicine. So it is sort of bread and butter in internal medicine. And majority of the patient in internal medicine that we have in our ward is more or less cardiac related. It could be in terms of ischemic heart disease, or it could be due to some valve issue, or maybe infection such as infective endocarditis. But majority is actually cardiac related. So most of the time, usually in your long case examination, majority of the patient that we choose is something related to cardiac issue. So you need to have a good knowledge and also exposure in terms of heart-related disease in internal medicine. And having said that, ACS is the most popular one. There are high probability that you're going to have this kind of patient in your assessment. Whatever is it, theoretical paper or maybe in clinical assessment. Okay, so yes, the learning point is that chest pain, you must remember that chest pain is not equal to heart attack. That's number one. Okay, because there are a lot of disease or any other condition whereby the patient might present with chest pain. So you need to know how to differentiate various form of disease presented with chest pain. Okay, and the most important thing is when you have patient who presented with chest pain, you need to exclude the most life-threatening condition first. Okay. What does it mean by life-threatening condition? It could be the most severe form of acute coronary syndrome, which is myocardial infarction. It could be in terms of pneumothorax, could be dissecting aortic aneurysm, and so on. Okay, so you need to exclude the most life-threatening condition first. Then after that, you need to exclude try to differentiate, sort of fine-tuning what is the more likely cause of this chest pain. Okay, because pericarditis, patient who presented with pericarditis, the nature of the chest pain might be differ as compared to other condition like pericardial effusion, or maybe just a simple pneumonia. Sometimes patients who presented with pneumonia might present with pleuritic chest pain. Okay, so you need to know how to differentiate between pleuritic chest pain and this angina pain. Okay, and in terms of management, yes, ECG is the number one. Okay, even in triage in emergency department, when patient presented with chest pain, the first thing that they need to do is chest pain, ECG at the triage level. Okay, so you need to know how to differentiate between non-STEMI, unstable angina, and also ST elevation, MI. Okay, and yeah, I hope you will have a formal session later on with regard to how to interpret ECG. Okay, I know that up to year 3, your knowledge in terms of ECG interpretation is very basic. In terms of electrophysiology, what is the P wave, QRS complex, and T wave. Okay, that is the most basic part of ECG. But later on, you need to know how to interpret the whole set of ECG, meaning that the whole 12-lead ECG. So where is the lateral lead? Where is the inferior lead? Where is the lead that indicate anterior or septal, posterior and inferior, and so on. Okay, so I hope you will have a good formal session later on with regard to ECG interpretation, because this ECG interpretation might be asked during your OSCE or even in your written paper assessment. And then in terms of cardiac enzyme, okay, yes, you need to know. Can you move to the cardiac enzyme part? Okay, cardiac biomarker. Do you have a graph on this? If you refer to most of the textbook, okay, they will illustrate the most beautiful various form of cardiac biomarker. Okay, there's which one that will elevated first. Okay, for example, troponin T, troponin I, and later on followed by the CK, CKMB, and so on. Okay, but in our practice, yes, troponin I and troponin T is the most sensitive cardiac biomarker that related to angina, that related to ACS. Okay, so not every center has this testing, but in our tertiary center like us, troponin T and troponin I is the gold standard nowadays. We before this we used to send CK, CKMB, okay, but now we are moving towards to troponin I and also troponin T, okay, and in terms of management later on, I think you will get this further detail regarding basic principle of management in acute coronary syndrome later on during year 5. Okay, so any other question pertaining to this case, chest pain? So you have complete all the case scenario for the case scenario that I have uploaded in the e-learning. So I hope you have a basic idea of how to take history taking, how to approach patient who presented with this kind of complaint. Okay, so I hope you will have a good practical knowledge later on when you start entering the campus. Okay. Okay. Any more question? If no question, we can wrap up here.
Doctor, I want to ask, do every hospital have PCI treatment?
Sorry, I tak dengar. Sorry. What's the question again?
Do every hospital have PCI treatment?
Do we have PCI treatment?
Every hospital.
Okay. In our center in HUSM. Your question is whether our center has this primary coronary intervention. Is it PCI?
Because I read like that not every center have PCI.
Yeah, betul. Okay, what it means by PCI is that, of course, from the guideline you need to know there is a specific criteria of which kind of patient who will most benefit from PCI. Okay, so there is a door to needle time, door to medication time, and so on. Okay, so not every center is a PCI center. Okay, and unfortunately, our center HUSM is sort of not really a pure PCI center. Okay, because you see, when to establish a PCI center, you need a good backup, you need a good setting in terms of staffing, in terms of cardiologists, but unfortunately, we cannot afford to establish a genuine or real PCI center in HUSM. Okay, but I think HRPZ, Hospital Raja Puan Zainab, more or less they are start to establish a well-established PCI center at their center, and many of the center in Klang Valley, okay, namely HKL, and of course IJN, okay, Sedang Hospital, okay, these are the most well-established PCI center that we have. Meaning that PCI center, it means that when patient who presented with chest pain and we diagnose the patient with myocardial infarction, okay, the first gold standard, the first thing to do is thrombolysis. With perfusion strategy by means of going for angiogram and also whatever intervention that needed, such as a stenting and angioplasty and so on. Okay, so that means by PCI. Okay.
Thank you.
All right. Any other question? Okay. If we don't have any question, maybe we can finish our session. Okay, we conclude our session now. Okay, thank you.